June 27th. This is the New York HIV Planning Council, and as we always do, we start with introductions. So I am your community co-chair, Matthew Lucier, and I work for NYCHealth. And going to my left,
David Clark, Planning Council staff.
Steve Emrod, Finance Officer.
Micah Domingo, Callenwood Community Health Center, Needs Assessment Committee, and Council Member.
Maria Diaz, co-chair, Tri-County, and also Planning Council Consumer Committee member.
Andy Strauss, Hudson Valley Community Services, and co-chair, Tri-County.
Jan Hudis, the Family Center, co-chair, PSRA.
I'm Christine Canalot, and Needs Assessment Committee.
Amber Casey, Grantee.
Tim Preston, Independent Consultant.
Rishi Kalu, Public Health Solutions.
Oscar Lopez, PSRA.
Asia Betancourt.
Carol Prensville, Columbia Dental Needs Assessment Committee.
And James Maldonado, Kings County, also consumer on the PSRA Consumer Committee.
Lisa Best, Tri-County Steering Committee, New York City Planning Council Consumer Co-chair.
John Sheck, consumer representative, Queens Needs, IOC, consumers, and this the Planning Council.
Chief Abdul Planning Council and Consumer.
Faye Barrett, Ryan Center, Chair of Rules and Membership and member of Needs Assessment.
Paul Carr, Consumer Needs, IOC and PSRA.
Charlene Graham, Consumer Committee.
Carmelo Cruz Reyes, PSRA, Emblem Health.
Eunice Casey, Health and Hospitals.
Good afternoon, Freddy Molano, Community and Network.
John Corbisiero, Parliamentary.
I'm Jan Park, the Governmental Chair for the Council.
who's on the phone?
This is Donald Powell, member IOC, Transgender Advisory Work Group.
Welcome, Donald.
Incorporated. Hey. Claire Simon, the Executive.
Okay, why don't we do, go ahead, Kim. Oh. Go ahead.
Kimberly Mack, Planning Council staff.
Leo Ruiz, Consumer. Rob Walker, Consumer. Terrence Garday, Department of Health.
Adrian Guzman, the New York City Health Department.
Mitchell Pepperoni, Community Health Network.
Eduardo Bader, Community Health and
Rose Chestnut, Planning Council, IOC, and I have along here my sister, Judith Hutchinson.
Jeff Mann, NYU School of Medicine.
Okay, so Jan, do you want to start?
Rose is asked to lead us in a moment of silence. Rose.
Good afternoon, everyone. I don't know if you all have heard about the gentleman that drowned in the Hudson River. Anybody?
I did.
Okay. That gentleman was the first doctor that I ever had since I got tested for HIV. He is renowned, world-renowned, does work in Africa. He's also a professor at UNC Chapel Hill, and he's a medical doctor and an HIV specialist at UNC Chapel Hill, which is located in Chapel Hill, North Carolina. So he has passed, and this is pretty much a dedication to him. So I'm asking you to bow your heads. Thank you so much.
What was his name?
Charles Vanderhorst, Vanderhorst.
Thank you.
Please Google him.
Good. So, Mr. Klotz, minutes.
Okay, everybody got the minutes right after the last meeting and again last week. Didn't get any changes or corrections. Any changes or corrections now? Not. Minutes are set. Thank you.
Are there public comments? Did anybody have a public comment for that? Okay, we'll move on for now. So, the recipient update. I believe that you are replacing Graham for the recipient update.
All right. Hi. So just a few things from us. The HRSA held a webinar a couple weeks ago on several policy clarification notices. And I believe last month we sent a summary of the most recent policy clarification notices. In case you're wondering about the numbering system, the first number, like 13, 16, 18 is the year that it was released. And then the second number is like what policy clarification notice that was in order that they're released. And so the most recent two were these ones in 18, as well as there was an update to the 13, which was being reported on last month. Quality management.
Question, were there any significant changes that they?
No, the only thing is that we are now allowed to provide services under presumptive eligibility, which I believe is what we reported last month.
Okay.
Which is something that we've vaguely allowed in the past, with the idea that if the person ends up not being positive, not being eligible, we would recoup. So HRSA was just clarifying that that is allowable, particularly the environment of IR and other things that we're really trying to push forward. And we move on under the quality management section. You'll notice this has been part of a conversation that we've been having here and in other committees for pretty much this entire planning year, which is around changes to eShare, into intake process to try to streamline it, try to make it more person-centered and service-centered, as opposed to just collecting data for data's sake, or senses of that is occurring. So if you look at the attachment, which begins on page 4, these are the changes that we are making to eShare in August. We'll be sending a memo to all providers, which will summarize, which service categories these are all applicable to, as they're not evenly applicable across the service system, but in general, these are the changes we'll be making. Adding things like some questions around food insecurity, some more service categories. We added some hepatitis questions, as well as some quality of life questions, which are a standardized assessment. Simplifying pregnancy-related questions, and then we'll also be removing some questions having to do with sex and sex behaviors, as well as drug use behaviors. And
I want to thank the department for removing some of these pretty onerous sex questions.
yes, I'm very excited. I've been trying to have them removed actually since I came to the department, and under our newer administration, there's been more reception to that.
And I want to say, Jan Park was a big advocate for this, I know, so thank you to Jan for pushing these issues.
We did advocate for questions that would enhance our understanding of people's disabilities, such as hearing, as well as we're looking for more questions to drill down on a person's oral health. I don't see them reflected here.
Those ones are still in process as we wait for your recommendations to come through your processes, so that we making modifications to eShare and to the assessment tools is a pretty onerous process. So we want to wait until you guys have sort of completed your processes so that we can fully address your needs before we add those.
Thank you.
You're welcome.
Good. Jeff, you had a question? Do you mind? Jeff?
Right off.
I thought you were finished.
Go ahead.
So have you gotten any guidance from HRSA about how people report poverty? Because on our Part C and Part D grants, we have to report poverty differently on a more frequent basis and assessment of the poverty level.
More frequently, you mean other than the every 6 months?
I have to go back and get that information. I don't know what the frequency is, but I was told by our data manager that it's a fundamental change in how HRSA is recording.
You have to report
to
the
HRSA.
Yeah, when you says eligibility for services, aren't you sort of measuring that?
So I think what you might be discussing is that, and we received similar feedback, but not about frequency. There are sort of two different things, right? So there's the assessment of eligibility, which occurs every 6 months. Once a year, you were supposed to obtain new documentation that sort of verifies, and at the other 6-month opportunity, you can collect just sort of an attestation that there's been no change. And that was part of the policy clarification notice. We also received feedback at our site visit that we needed to be better about collecting actual amounts. And maybe that's what you're discussing. So often what we've done is just sort of collected ranges, or you have Medicaid. Medicaid has already verified your income, so we weren't re-verifying income. And so we received feedback that we should be collecting some type of number around income. And so, but we won't be collecting that as a, it's just that we just asked now for a number. We won't be collecting additional documentation. So we also held a providers meeting for our care coordination contracts. As everyone may remember, last year we rebid our care coordination portfolio. So we hosted staff from 25 programs to meet and reflect on this first year of care delivery, and to hear about their experiences with some of the changes we made, such as being able to use video conferencing, more work around assessing self-management skills, and on serving transgender and non-binary folks. And then the rest of the grantee report comes from the Bureau itself and our larger work. It's related to, but not necessarily entirely within the Care and Treatment Program. There was the long-term survivors event. I did see lots of familiar faces there from the council. It was a really great event, and I hope everyone who was able to attend enjoyed. We co-hosted that with the Long-Term Survivors Wellness Coalition, and approximately 135 folks attended. The Bureau also participated in pride events at the Queen's Library. BHIV has, as many of you may know, Graham Cameron normally is in this seat, is the chair of the CARE Coalition, which is the advocacy organization for cities, in particular the Part A grantees, as well as some C grantees and other grantee types to advocate on behalf of Brian White grantees. And they've been engaged in activities down in Washington, D.C. And then finally, Dr. Blackstock, the commissioner of the Bureau, attended the adherence conference in Miami, Florida, and presented on the work the Bureau is doing around, again, IR, or immediate ART implementation. Any questions?
Lisa.
Could you just elaborate on the communities advocating emergency aid relief? Is this like when there is emergency situations like weather-related disasters, or?
No, the emergency part comes actually from the original CARE Coalition, original Ryan White CARE Act legislation. The E in CARE was emergency, with the idea that this funding was for an emergency, the AIDS epidemic at that time. And so the word emergency is actually related to that, not to like natural disasters.
Thank you.
Amber, can you speak to the Make Equal campaign that's been launched?
Oh, wow, there's a whole other page of stuff. Sorry, I did not prepare this. I do not know a lot about it, but the health department has launched a new sexual health marketing campaign. This is on page 3. And it is called Make Equal. I actually saw it today in the wild on my way to this very meeting. And it's really around continuing to promote the U equals U messaging and encourage all New Yorkers to understand their options when it comes to sexual health and to take control of their sexual health, whether that be HIV treatment or HIV prevention, regardless of sexual identity. And so we can continue the department's stance that sexual health need not be fear-based, but instead could be a celebration of sexuality. And before that, sorry, I missed this one, and then CHUB presented at the mayor's office to end domestic and gender-based violence around our ending epidemic activities amongst young people. Adrian, who I believe is on the agenda later, as well as Anisha, who's our director of racial equity and social justice initiatives, talked about intimate partner violence and HIV and how those things relate to the blueprint and to our activities at the department.
Yes, Billy.
Actually, today at 6 o'clock, the May Equal Campaign Celebration is going to be held at the Howard Field event space at Theater at 137 West 26th Street.
Yeah, it's at the bottom of the page 3 of the grantee report, that address, and that's free and open to the public.
This is unrelated. Well, you mentioned U equals U. I just have a question, and maybe somebody can answer. U equals U says that you have to be undetectable for 6 months. Let's say you're undetectable and then you become detectable. Do you have to live in those 6 months? Is there something that carries that?
You know, I think the hard thing about these sorts of campaigns, right, is there's the sort of general messaging to the public, which is what we do through ours, and then there's the intimate conversation that you and your provider have about your own health, or you and your partner have about your own health. And I think as I know that you work in a peer educator sense, and so I imagine that you're having those conversations with people. And I think, you know, the messaging in the science is 6 months, but you know, I don't know with a individual person situation. Like, do you know what I mean? Like, it's always a hard thing. Like when we talk about like the cascade of energy, and I've had this conversation a couple times, right? We say suppression is less than 200, but your doctor is going to make very different decisions about your own health if you say have viral rebound, right? So.
Terrence Carty, the governmental chair for the HBG, is here. I'm wondering if he wants to weigh in on this question.
On that note, there are 2 new council members who've arrived. So if you want to announce yourself.
Hi, Bill Rose from Sage.
Ronnie, say hello.
Hi. I came in a little late on one.
Microphone. Oh, thank you.
I just wanted to follow up on the U equals U question. Amber's exactly right. Our main message is to direct people to have these conversations with their providers who has the most information on what's right for you. And I think that a lot of these questions can be answered too on using materials that we have on our website. So we're working really hard to educate providers about the science, but there's also tons and tons of information on the health department website that's public-facing as well as provider-facing. We have FAQs, dear colleague letters, all of that. So if you just go to the health department's website and type in HIV U equals U in the search engine, you'll see our U equals U page, and all of these and more questions the answers are available there.
John?
The problem with all this information is that the consumers are believing it's the cure because they can't transmit it. So they're cured, and that's the problem. It's not the U equals U, it's the problem is they think it's a cure, they're cured, and they can't transmit it.
Yes, Chet.
What's the main difference between the Made Equal campaign and the U equals U campaign? Or is it the same thing, but just different words?
I think it's just marketing.
Thank you.
I think this is points out a disconnect between the Planning Council and the HPG and prevention work and treatment and care work. So this huge campaign has been launched, and none of us at this table know about it. And yet you're all HIV experts. So you're going to be asked questions about it if anybody relates to the fact that you're sitting at this table. And so I've consistently been an advocate that we have a prevention moment as part of our agendas in this meeting. And I would advocate that that the HPG have a treatment and care moment in their agendas. So at least each of these bodies know what the other one is working on. So I think for July, if we have time, we should invite someone to come in and speak about the campaign. Because I know that since I work at the health department, people ask me questions about that all the time. And I don't know the background, and I don't know the backstory, and I can only speak in really kind of general terms about it. And I think the next session, you should really commit to having a prevention moment at these monthly meetings.
Friday, and then Billy, and then we're going to move on with the agenda because we're still on just the first agenda item.
Thank you. I just want to follow up on Jan's because those are very valid questions. The U equals U, now we have another name. As my colleague mentioned, the consumers will get more confused now. We have been talking about U equals U for the last couple of years, maybe 3 years. Now we come out with a whole new different name. It's going to be confusing. This campaign is working toward eliminating it and making it undetectable. We don't need to change that in the second year and the third year. We should be capitalizing on the successes of the first year. Again, John, you're totally right. Doing this all over again is not going to help consumers, which has to do with it. Thank you.
You're on, Bill. I'm just going to say this. When you're watching television and you're seeing advertising HIV drugs, and then they don't even say in the commercial, your viral load will be suppressed and you can no longer transmit the virus. They're not saying that. They're not saying, and this is a problem for people when they're seeing these drugs being advertised on the media. And like you said, and like Janet said, there has to be some type of a standard about this whole thing.
So I'm going to break my rule and allow Steve, go ahead. Now we need to move on with the agenda. So go ahead.
So what I find very interesting, Big Target, of that advertisement, and it does talk about the EU equal U in it. If you stay on the document, you can get it. That was the first time I saw a U equal U in a Big Target, but it's in the Big Target advertisement.
Okay. Very healthy conversation. But we do have some votes we need to take, and I want to make sure we have the time to have those conversations as well. So Jan, you are up now for priority setting resource allocation.
Okay. Number one. Okay. Is that better? Okay. I'll try
Just use another microphone.
I don't think I'm not sure. They instructed that the phone microphone is on.
Oh, go ahead. Yep.
Okay. Okay, so the first thing we're going to discuss is the first thing we're going to discuss is the FY 2020 application spending plan. And there are 3 spreadsheets in your packet that provide detail on the application spending plan and the various pieces that go into this. So just by way of context, to note that the spending plan that we're presenting is really focused on our request for an increase in funds. HRSA is very likely to cap this increase in funds to 5%. And there's also very, very small likelihood that we will actually get this increase. So, so just to keep that in mind while we're discussing the application spending plan. So we
Jan,
always...
hold on before we do. So we just got some technical advice. People on the phone, I think the feedback we're getting in the room, maybe because someone's not muting your phone. Can you just please, if you're on the phone, just mute your phone unless you're going to talk? Thank you. Okay, Jan.
And just by word, so we always ask for the maximum that HRSA allows us. We believe that's going to be 5%. So the figures that are presented to you today are assuming that we'll be able to ask for the full 5% over what we have this year in funding. So again, this is a theoretical request. We don't expect an increase, or at least not much of an increase. And then as a word of reminder, if we do get an increase, we will go through a whole process in the fall around scenario planning where we will really be able to dig down if we do get an increase and make we will reevaluate the decisions that would get made for this in this process for the application. So any decisions that are made today are not binding decisions. We are, for the application, required to submit spending plans for both the base award as well as the MAI award. And you have an MAI spreadsheet. It looks like this. It's relatively short. And that indicates that actually, and basically, the funding request is completely formula driven, so we actually are not requesting an increase for MAI funds, and that's illustrated here, where you'll see that there's no increase. David, you want to, so it's this spending plan which shows that the current funding is at
8.6 million.
8.6 million, and it remains the amounts being distributed across programs is the 7.755, correct? And that remains for this coming year.
Correct.
And then you also have a spreadsheet that documents the Tri-County process. And the Tri-County process, the Tri-County is also asking for the maximum 5% increase. In this case, it's all going to come out of the base award, because all Tri-County programs are base funded. And Tri-County has requested that that increase be evenly distributed, be proportionately distributed across the entire portfolio. And that's what's documented in the Tri-County Steering Committee request, which is the second spreadsheet. And you'll see there that the request is for an increase of $224,880 to be distributed proportionately across all categories. And then the New York City piece is in the larger spreadsheet. And here you'll see that we actually made some distinctions. We did not request proportionate cuts across the entire portfolio.
Increases,
Oh,
Jane. Only increases. We don't have about
increases,
cuts today.
Increases across the entire portfolio. We are requesting the full 5%, which if you look in column F, F4 is the total amount of, that's the 5%, correct? The 4,287,92. And when we remove what's going to Tri-County and what's going to New York City administration, it leaves us with $3,627,833 to distribute across the portfolio. Is that right? Okay. And so our PSRA had a lengthy, detailed discussion about this, our proposal is that we make targeted increases in the following way. And you'll see this on the spreadsheet. So if you look at food and nutrition, which is, if you look at column K, row 15, you'll see that we are proposing a $1.45 million increase to food and nutrition. You'll see then in column K, line 16, we are proposing a $1.480 million and change increase to housing. You go down to column K, row 22, where we're proposing a $450,000 increase to supportive counseling. And then the fourth increase that we're proposing is to the legal portfolio for $247,000.
I have a question about this. So the four categories, in the event that we receive an increase, you've identified four categories that you would target the distribution of that increase. So what was that based upon?
So this is based on so food and nutrition. So to start with food and nutrition, this is actually an increase that was discussed in detail last year when the decision was made to increase the food and nutrition contracts to expand the reimbursement rates for services and not to make the additional expansion for capacity. And so this is really picking up the capacity expansion this year. So that's the specifics around food and nutrition. Housing is a category that we have discussed many times. We know that it's a need, and everybody, well, it's a need. We know that it's a multi-contract type portfolio, and that within that portfolio that there are contracts that are in a sense artificially capped because they're being we don't know how much need there is for expansion because we can't fund more programs without knowing that there's actually money there to fund the services. And so there was, based on the feedback from the Department of Health, there is confidence that there is need that can be fulfilled, that will be able to use this funding and will be responsive to need in the community. That we don't really, because there are no wait lists, there can't be a wait list, so that's that need. And then SEG and legal services are traditionally overperforming categories. So that was the basis for those four targets. And other categories were discussed, but those were the categories of funding that were considered to be the ones that we had the most data and need.
Thank you.
So any other questions about the proposal?
So are you introducing a motion on behalf of the committee?
Yes, I am on behalf of PSRA moving that the Planning Council accept the FY 2020 New York City, the base New York City, MAI, and Tri-County application spending plans as presented.
So there's a motion on the floor. Are there any questions on the motion before I call for a vote? Everybody understands what they're voting for? Okay. All those in favor of the motion, please raise your hands. Keep them up so David can do a head count. Although it looks unanimous to me. Yeah. Is there anybody opposed? Yeah. All right, that was unanimous. Thank you, everybody, for that motion. Okay, so you keep going, right? Yeah.
The second piece of this is we need to vote on the carryover plan. And that's documented on this sheet right here. And this is something that we do every year. And as a reminder, this is our plan for how we're going to spend funds that were unspent in the contract year that has just closed out. So the contracts ended at the end of February, and the closeout process is almost done or done. And so we know that the unobligated balance, or what we have to carry over into this year, is approximately, it will be very close to this amount, is the 276,373 that's under in the unobligated balance column. And that represents a very, very, very small percentage of our total award. So congratulations, everyone, on spending your dollars, and to everyone who manages the contracts. So the plan is, frequently what we do is, in this process is we request that any unobligated balance be allocated to ADAP. We did not do that this year. We actually had a request for providing $200,000 of the unobligated balance to housing in Tri-County. And this is because, so I don't know if people remember that when we funded Tri-County Housing for an additional $300,000 a year ago, but the money was received in Tri-County rather late in the contract cycle, and so in order to make sure that they spent the money, they over-contracted. And so, well, they have more people in housing than they have money to support in housing long-term. And so they have a need for an additional $200,000 in order to be able to keep those people housed. And so they have asked that we allocate the $200,000 to be able to maintain those people in their housing. Is that correct? So, so we are asking this year that we allocate $200,000 to Tri-County Housing, and that the remainder of the unobligated balance be allocated to ADAP. We don't exactly know how much that will be. It will be around $76,373.
So this $200,000 for housing in Tri-County carryover dollars, one-time dollars, it will fix the problem temporarily, correct?
Yes.
So what is the plan going forward?
So I'll let Pam.
Pam, who's the director of our housing, and I met to discuss this issue, which is how
Excuse me, can you pass on the mic?
Oh, sorry.
Thank you.
So Pam, who is the director of the housing unit of the department, and myself met to discuss this issue, which is how the request came through. We are planning a meeting with the two contractors to discuss sort of plans, sort of understand what happened, understand what they anticipate to be sort of the attrition, and then, if necessary, make a request for either permanent funds or try to figure it.
Or eviction.
Well, I mean, there is some level, not all of these funds are used for permanent rental assistance, right? there is a level of attrition. Some of it was used for, was used for arrears. There are other things that we can pay for that it was. So we're going to sit down and figure out sort of what to carry the clients who they presume will be in long-term assistance. What does that cost? And then potentially make a request to the Planning Council for additional funds in the fall. But since this money was available now, and it was about the same amount, it seemed like a good fit to take care of 20.
I think, this council has always allocated resources proportionally, but there's no reason why we couldn't change that scenario. This is a really important need, and I hope that the department will come back to this council. If it needs, we need to permanently change the allocation to save people from becoming evicted. I think that's a sacrifice we should be willing to make.
Yeah.
I saw 2 hands up. Jesus, and then Billy.
Okay. I apologize, I wasn't at the last meeting, so I didn't get this, I didn't see this information. My question is, every year we've given it to ADAP because I understand that the carryover has to be spent within a certain time frame. And I'm just curious, I'm sure it's taking this into consideration, but I'm going to ask a question anyway. Can this housing, given it to the housing unit, will they be able to spend that $200,000 within the time frame?
That's why we did up to 200,000. So I think the actual math works out to like 190 something between the two is what they actually need. So we'll give them only what they can spend, and then the balance will go to ADAP. And that's how we'll address that issue.
Okay, so, oh, sorry. Billy's next, and then John.
I just wanted to know, with the 76,000, we into the 73 that's going to prescription drugs. I understand this whole process, but when you talk about $689.91 for prescription, are you talking about that ADAP is going to match dollars with this to cover prescription for drugs?
No, this is money we give to ADAP for prescriptions. This is the cost per prescription.
On average. We had to give HRSA like exactly how we spend the carryover money, how many pills, how much per pill, same like housing units, the same idea, how many units, so that's why it's this detailed in here, that's the only reason. You good?
No.
Okay, John and then Jeff.
No, Billy, what was the question?
Well, I just know that the prescription costs at least about $1,500.
This is the average cost per prescription. So that means that sometimes we cover, the formulary isn't just HIV. So the formulary also includes things that are much cheaper and things that are much more expensive. But overall, this is the average cost per prescription of the ADAP portfolio.
John?
Formula.
Okay. Now, I understand the real importance of having housing and having money. But if we don't give the ADAP, how does that affect the relationship between the Planning Council and ADAP?
We're still giving ADAP, we're just giving a smaller amount.
Yeah.
And we're still, in the full spending plan, there's still a...
Yeah, but I thought I understood saying that we're not giving ADAP.
No, just not as much.
I just want to remind everyone that the budget for ADAP is 3 times the size of our budget.
This is a small amount. So, did you have something to say, Jeff?
Amber, when we have carryover money, does that carryover money reduce the budget from the next year by that amount?
No, carryover in Ryan White, as long as you're under in Part A, as long as you're under the 5% cap, it is additive, not deductive.
Yeah, and I would just add the reason why we usually allocate carryover to ADAP is because we have to use carryover by the end of this fiscal year. The person generally approves it late in the year, and they are guaranteed to be able to spend it. Also, if we do not spend the carryover money, then they deduct that from the following year's award.
Okay, everybody good here? All right, so is there a motion right here?
Yes, there is a motion, and on behalf of the PSRA, I move that the Planning Council accept the FY 2018-2019 carryover plan as presented.
Motion's on the floor. Lisa, you have a question on the motion? Okay. Right now, we're just going to discuss the motion. Is there any other conversation before we vote? Okay. All those in favor of the motion, please raise your hands. Looks unanimous again. Thank you. Anybody opposed? Okay. Thank you. I want to say something. Jan, is this your last? So I have seen, you have really grown amazingly, and your subject matter on this is really, really very impressive.
Oh, thank you.
So I want everyone, I really want to thank, on behalf of the entire council, thank all the work you've done at PSRA. Because,
To David for providing, and Amber for providing all the support, lots of spreadsheets and narrative and assistance in understanding the ins and outs of a rather complicated budget process.
Yeah, and both you and Matt are staging off the council. Your term limited, so you know, it's a shame because you two are both great chairs, and so you'll be sorely missed in that role.
Thank you so much. It's been a real pleasure and honor to serve in this capacity. Thank you for all of your patience, and a shout out to everyone on PSRA. If everybody could, on PSRA could raise their hands a lot. I mean, I think almost everybody's here. So thank you very much. It's not easy to stick with the details of this. So.
David and then Billy.
Matt stole my thunder. I was gonna say the same thing. So both Jan and Matt Bainey are cycling off the council this year and have been just magnificent chairs, and it's been an absolute pleasure to work with you and support you, and your leadership has been just stellar and impeccable, and it's just supported people's involvement and made things understandable and made the whole process inclusive, and I just, again, want to thank you for your work. It's been amazing.
Can we chant 4 more years?
Sometimes term limits are good. Not in this case, but sometimes they are. Did you want to say something?
It's kind of like one of the because I was going to say what David said, because during your tenure, you have simplified this process that I no longer go home with a headache after all of this spreadsheets, and you made this committee so well that the consumer committees on it and speaking up about issues within this process. So thank you so much for your years of work with us.
I also want to acknowledge Saul, who's not here, who is I think is still a member of PSRA, but had to sort of stop coming to meetings because he had another commitment come up. He really pushed us to simplify and document, especially from year to year, what we've been doing, so that there will be more historical knowledge, and I think a cycling off everything will be fine next year, because there's really a great, there's a good historical record of what we've been doing, which will really help moving forward, and definitely the involvement of everyone on the committee in terms of demanding that we make it that we make it easier to understand, and that we have more documentation to sort of help us keep track of the discussions that we're having from year to year is really important part of that.
So I'd like to say there are some new council members who come in after we did roll call who want to announce themselves.
Amanda Locke, After Subsistency, and co-chair of the New Subsistency.
Hi, good afternoon, everybody. Sorry I was late. Marcy Thompson, Lines for Positive Change, and co-chair of the NA committee.
Chair, if you want to.
All right. So Amanda and Marcy, you want to say something, Lisa? I'm sorry.
Yeah, I wanted to thank you for mentioning Saul Reyes. I found out, as with the rest of the consumer committee members at our consumer committee meeting, that was his last meeting, and it was interesting because something in me said I wanted to remember and recognize that I don't think we appreciate the work and the detail that Saul paid attention to in a lot of the work on whatever committee he was serving. He was the reminder of parliamentary procedure when the parliamentarian wasn't in the room. So I think that he's going to be very well missed. What I'm a little not happy about is, as a committee member and traveling to the meetings and putting in the time and being committed, that he's not even here at the general committee meeting to hear what's being said. I don't think that we should allow committee members that are that dedicated to just ease out, and we're not able to give him the accolades, because it's like, I don't want to use funeral for Saul, but why give roses when you didn't smell them?
Well, don't worry, we have a meeting in July, and that's the time when we recognize people. We've already recognized Saul as he's announced his departure. He's in school now, so he's either in class today, or he's working on the paper, or, I mean, he has really legitimate reasons for not being here. But yeah, I just support everything everybody has said. He's been a pain in the ass at times, but you know, he really does hold our feet to the fire, and underneath all of the drama there is always a reasonable question that he has that we ought to be holding up a standard where everyone can understand what we're talking about, and that we can put it forward in the simplest and clearest way. And he's just an example that there's no question that is wrong. You know, every question, if there's one person asks that question, 5 other people have the same question in their mind. So, kudos to Saul.
Thank you, everybody. So, moving on with the agenda. So I know Amanda and Marcy are chairs of needs assessment. I don't know, but you're not going to be doing this presentation, are you? I don't know if you want to start off the conversation and introduce the presenters.
Hi, everybody. My apologies as well. Not late. So it came to the attention of the needs assessment committee via members and consumers that there was a need for us to review oral health and develop draft recommendations for the Planning Council on Oral Health Service Directive. A big part of that, a huge part of that, was led by Paul, who's going to be one of the presenters, along with Melanie, who's the other. They've done a phenomenal amount of work on this, convening the meetings on a Friday, and also culminating in an excellent forum that we held last week at New York Technical College in Brooklyn. So over to you guys with thanks.
Good afternoon, everyone. It's good to see you. So I really want to thank Paul. He and Carol Kunzel took the lead and served as co-chairs and gave up afternoons and sometimes random times during the week in order to make phone calls and sit on conference calls and listen to some stakeholders, other stakeholders in this process. And really, Paul has been tireless in pushing this whole issue forward, and we learned a lot of things that I can never unlearn, but really indicate that there is a significant need in the city for these services. Paul, do you want to go through the synopsis, and I'll do the recommendations?
Thank you. Before I go on, I also want to thank Carol and Melanie and the rest of the committee that came as well on every Fridays. And if you guys want to raise your hand so everyone here knows who's here, that's great. Thank you. And also Melanie, she's very modest because she also was running some, the work of, I think it's 3-4 committees going on right now. So, I don't know how she gets her energy, but and she's doing some of it while she was in Jamaica. As you know, we did meet on Fridays, and the synopsis, I'm just going to go through and read the synopsis. Oral Health Subcommittee was formed on behalf of the Needs Assessment Committee. The call for a subcommittee was based on testimony from Planning Council consumers around their ability to access comprehensive oral health services. Oral Health Subcommittee received presentations from Chain, an and interviewed several leading providers in the field, Dr. David Resnick, Elena Bednarsh, Dr. Judy Moy, as well as Tri-County's oral health provider, Dr. Powell. The committee also spoke with ADAP, a major funder of dental services in the New York City area, to better understand what procedures are covered and what the process for assessing services entails. Medicaid only covers essential services and does not adequately cover the oral health needs of PLWH. It provides low reimbursement, frequently does not cover replacements for lost or broken dentures, uses the cheapest quality materials, and does not support dental work that preserves the long-term oral health of patients. Dental case management has been shown to reduce anxiety, improve engagement through education, and patient preparation for receipt of services. Dry mouth due to medications is no longer a major issue for PLWH, for people living with HIV. Although it does not continue to impact some, it does continue to impact some patients, my dyslexia popping in there. But issues of candida and thrush due to use of inhalers is prevalent. Comorbidities are a major concern. Some surgeries cannot be done when a patient has untreated dental problems. Partnership with major institutions can be difficult to establish, but are critical to ensuring access to comprehensive, sustainable, and recurrent dental services. Lower denture needed to be seated in a patient's mouth. Medicaid recently improved implants for the purpose of holding the lower denture in place, but coverage for bone grafts continue to be a challenge. Consideration of oral health is not currently included in Orion White Part A intake, reassessment, or screenings, and only normally addressed in food and nutritional programs. Just to note, though, that the grantee is waiting for some of our recommendations as a result of the work we've been doing so far. Thank you. Stigma compounded by fear and anxiety continues to be a major issue impacting access to oral health services. Persons living with HIV require to bring blood work without adequate explanation, further indicating the need for dental case managers. Part F, once a safety net, is now described as non-functional. Community-based providers such as Callum Ward and Mount Sinai are fully booked. Callum Ward plans to expand the number of dental chairs and providers to meet the need. An oral diagnosis with a full set of x-rays and a thorough dental history should be the critical first step in developing a service plan for the patient. Substance use, depending on the form of consumption, can severely exacerbate dental issues.
So I'm going to cut in because we got some data back from the Medical Monitoring Project, which is a project, a collaboration between the CDC and the Department of Health, where not only do they do interviews with people living with HIV, they also do medical record extraction from the doctor of choice that the patient in doing the interview names. And so I wanted to include it because we literally just got it like yesterday. I wanted to include it because our colleagues did a lot of work to provide this information. They didn't just do medical monitoring, they also looked at people with disabilities and SMI, which are the other subcommittees that are, which are the other, is the other committee work, it's some other committee work, some of the other committee work. And so if you look at this chart, you can see that viral suppression, so the Medical Monitoring Project interviewed about 1,000 people, like 1,004. Of the people who said that they did not need, that they did not get dental care in the past 12 months, something like 350-ish, you can see that for people who did need that care, Oh, and I want to note that most of the people in the medical monitoring project are in care, right? They've had contact with physicians, their lab data, their lab work is up to date. There are very few people who are out of care in that study. They're trying to increase the number of people who are out of care, but it's like under 5. So this is for people who are considered to be quote unquote in care. You can see that viral suppression rates for patients who did not get dental care in the past 12 months, but needed it, is significantly higher than Okay, I'm sorry, I think I did it backwards. Viral suppression rates for people who needed dental care but did not get it is significantly higher than for people who did not need dental care and did not get it, right? So there is an association between, I don't know if I'm saying any of this right. There is an association between unsuppression, like lack of suppression, and a need for dental care and having access to dental care. So a lot of the work that we did found that this is an amazing touch point, like a way to reach people in the system, to get people to touch the system and provide services that wrap around the dental services that folks need. And you can see the trend continues. I really don't think I did these like this morning right before the managers meeting. So you can see that the trend continues, though not as significantly for retention and care. Oh, did I? Yeah, I messed these up. But I'll send out updated ones at the beginning of next week. You guys will receive updated charts. Anybody who has questions, please reach out to me. So the recommendations that we came out with, to fund oral services, the umbrella recommendation, the overarching recommendation is to fund oral health services in New York City. The current service landscape is neither robust nor comprehensive, resulting in gaps in care. Only 33.7% of chain participants, who pretty much mirror the Ryan White population, have reported that they received oral health services in the last 6 months. Ryan White Part F has not been sufficiently maintained to meet the needs presented by consumers. So it's a combination of like a lack of robust funding, as well as organizations that are willing to take up the mantle and receive kind of like pennies on the dollar. Where coverage is available, i.e. Medicaid and ADAP, needed services are not included or easily available, such as gum and bone grafts, crown and bridge work, partials, implants when just one tooth is missing, and replacement for lost broken dentures. So the issue with Medicaid is largely that when you're thinking about your oral health care and you're thinking about like the long-term preservation of your ability to chew food, that's not what Medicaid is thinking about. Medicaid is thinking about how do we address the issue right now, just figure out what you need for now and not think about the long-term process. So our second, I gotta do 2 things. So our second recommendation is for routine oral health and engagement screenings. This means incorporating a screening tool into the intake. So develop a screening tool with validated questions to identify oral health discomfort and issues among consumers. And I'm sorry, Paul, I'm supposed to follow up and identify 2 appropriate questions to go into the intake. I will get to that soon. Ensure linkage to oral health services, and develop health education modules that incorporate the need for dental services and oral hygiene. So we want such information to be incorporated into medical nutrition therapy. We want it to be offered in the food and nutrition programs, as well as in care coordination, harm reduction, health education, and risk reduction. We feel like this is an excellent touch point in essence, and that we should be following up and making sure that folks understand that their oral health care is connected to their physical health. Our third recommendation is dental case management. Many of the providers that we spoke with had nothing but accolades for quality dental case management. It gave opportunities to address social isolation, to reduce anxiety, to improve consumer engagement and education. As our portfolio, as our population ages, social isolation is a higher and higher threat to people's health and well-being. Dental case management can help address that, right? Consumers diagnosed with HIV usually have more complex and untreated dental needs. Dental case management can help people navigate through a complex dental plan. It also links consumers to appropriate services, provides follow-up, and promotes dental education and preparation for receipt of services. It's also been shown to improve engagement in services overall. We'd like to include linkages to smoking cessation and educational interventions. So it's not only an opportunity to deal with and work with the consumer on their needs, it's also an opportunity to bring in things that they might not want but can then understand the importance of. Not everybody wants to quit smoking, but it's a good idea for everybody. Our fourth recommendation is linkage agreements to specialized complex and emergency services. Dr. David Resnick noted that establishing these agreements can be tricky. It's not, we all know that Ryan White does not reimburse at the highest rates, and it can be a complex thing to navigate, but having these linkages will ensure that there are critical and appropriate comprehensive care for consumers. Providers should be required, all providers who provide this service should be required to link to institutions that can and will deliver specialized services such as implants, complex bridge work, scaling, and other types of oral surgeries. We want to make sure that emergency care is funded and available. We want to provide coverage for implants and other highly specialized services such as crowns, orthodontia, and gum and bone grafting on a case-by-case basis. We recognize that, like, a full set of implants is not necessarily good use of Ryan White funds, but we want to make sure that that people have somewhere to turn when they do need these things. All right. So we also want to recommend that we support the use of quality dental materials. We heard mixed messages from providers about what kinds of dental materials are the best for folks living with HIV and just in general for different procedures, and so I think that's something that's going to have to, that we're going to have to look further into, like what should we recommend, what should be the gold standard, what should we cover. We want to allow the use of food vouchers for electric toothbrushes such as Quip and other oral hygiene products. And our sixth recommendation is the development of guidance for comprehensive oral health care for people living with HIV. So we want a lot of this is just a lit review, gathering and recommending comprehensive, preventative, and recurring dental services and procedures that all people living with HIV should have. We want to definitely ensure coverage of at least 4 dental cleanings per year. The literature is pretty clear that people with HIV have more complex dental needs, and that 4 cleanings a year will help stem a lot of those issues. And currently, ADAP does cover it, but you have to have ADAP coverage. It has to be approved on the day of. Your coverage has to be, it's like a very complex. So this would, I think, really open it up for a lot of people living with HIV who are covered by Ryan White. We'd like to see recommendations developed for common comorbidities such as diabetes and hepatitis C. We want to require trainings that address stigma among dental providers. We want to complement Medicaid and ADAP services to ensure a robust system of care, develop guidance on how viral load impacts oral care so that consumers can be educated about what's happening with their bodies, and we want to address HPV. Any questions? Lots of questions.
Jesus, then Lisa, then Tim. I don't know if it's the job of the needs committee to do this, but have we come up with an idea of how much money needs to be allocated for this? That's question number 1. Question number 2, I'm not part of this committee, and I know that when I've asked for ADAP providers for dental, the majority of the providers are in hospitals. And I know at Kings County, for instance, the waiting area in the dental department is significant, the waiting time. Are we going to link with other non-dental providers that there's more variation of where you can go? And thirdly, does this money, so do you have to go through Medicaid first and then ADAP, and if they don't pay, then it comes to us, or are we going to fund ADAP? Those are the 3 questions.
So all Ryan White payer of last resort rules still apply. This isn't, you can't just pay for a service if there are other payers available. Yes, we'd like to see a mix of providers funded. I think how the IOC develops that language will really speak to that. And third, no, we did not develop a price tag because that is not the mandate. That doesn't really fall under the Needs Assessment Committee. That's PSRA. So in that way, everyone kind of gets to touch the recommendations.
This is only the first step of a 3-step process. So from here, if it proceeds, it has to go to integration to IOC to develop a service directive. And then after IOC, then it would go to PSRA. So there's several steps to go. And so questions around that or stuff I think would be answered in the development of a service directive in IOC. So this is more of a concept paper, I think, at this point. It's not like we're ready to go and roll it out tomorrow. Lisa, and I know Jeff had a question.
So thank you again for the work that you did. This is really, I'm very excited about what can come out of this with the continued work. What I do want to say is, I said this earlier, regarding dental health, some of us consumers after executive committee, we're using oral health as something that's separate and distinct in healthcare when it is absolutely correlated to a lot of individuals' health. And I think maybe we need to start looking at this as just healthcare, period, because it affects so much. So I'm saying all of that to say is payer of last resort. I'm trying to keep all my thoughts together. Payer of last resort, I've been hearing this since I've been the steering committee member and now a planning council member. And since 2010 when I was in ICU critical condition from a badly pulled tooth. I've been since 2010 trying to understand, gain more information, when needed, access that kind of service, and it's 2009 and I'm still having difficulty. Recently, I was referred to a service in the Bronx. They're no longer taking new patients. Tri-County has 2 providers, Westchester Medical Center and another place in Yonkers that I've lived in that neighborhood 38 years, I would not go. Why am I saying all of this is because not a lot of consumers would know how to ask for Part F. That's number one. Some of the providers, case managers, aren't even familiar with Part F to be able to make the referral. That's number 2. If you're calling a dental provider and they're saying that they're not taking any more new cases, then, and this is traveling into the Bronx, where the payer of last resort is a concern for me, it means Medicaid is cut off. Medicare, I have Medicare, which provides absolutely no dental coverage. So in order for you to be the payer of last resort, your Medicaid has to be cut off, which means you're not getting transportation.
When I'm saying that's not true, I'm not disagreeing with what you've experienced. What I'm saying is that someone can have Medicaid and Ryan White, and if Medicaid doesn't cover the service and we do, then we'll pay for it. So so for instance, Medicaid doesn't cover replacement dentures unless it's like 7 years. So you're basically, if you lose your dentures or you break them in the first year, you're just like, hey, you're just there without teeth. So at that point, Ryan White, if we cover dentures in our service directive, we cover the replacement of them, Ryan White would pay for it. We wouldn't just be like, oh, well, Medicaid doesn't pay for it, so we don't either. Like, that's us filling the gap. But your experience, I think that shouldn't happen.
No, well, and the thing with around the Medicaid, and that's what I'm really getting at, is the awesome work that gets done around the planning council on paper and in theory is absolutely wonderful. However, when it starts to get applied in practice and you start referring people who are already frustrated with a system, getting into a system that is beyond frustration, not to have someone tell you that they have to pull, you can't chew. I can get into all of that, but you understand where I'm going. And the last thing I wanted to say is I really think that this planning council doesn't talk about this enough, not since I've been here. And I really think that we need to have a dentist professional to come and do a presentation on the correlation between dental and health moving forward.
Lisa, I would just like to add to your comments. This subcommittee has been concentrating very heavily on all the different things that aren't happening to people when they have oral health challenges. And we had some of the best HIV dentists, best dentists that treat people with HIV come to the committee and share with the committee their experiences and where they see the gaps. And I'm sure they'd be more than happy to come in the fall to present to the full council. It is a hodgepodge way of treating a person's health condition. But we do have a dental program in the Tri-County region that is funded by Ryan White dollars that has a service directive that outlines the components of what would be delivered in that setting. And it's a successful program. And the dentist that treats people at the Westchester Medical Center came and spoke to this committee as well. So this set of recommendations comes from a lot of work. And there are many jurisdictions that are Ryan White funded where oral health is right there in the top of the list, either number 3 or number 4 on the list of needs and services that are being provided. It's always been curious to me that we've never had it on our, or as long as I recall, on our part of our service directives. So it's time. And I think that these recommendations touch upon all of the disconnects that people experience when they go to seek dental care and are Ryan White clients.
So Tim, you've been waiting patiently to speak.
Melanie answered my question.
Jeff and Billy?
I just have a question about one of the recommendations on dental case management. It seems to me that a lot of the case management-esque services that are recommended here are duplicative of the normal case management program. So how would you take that into account with organizations that already have case management programs that are providing a lot of these types of services?
Well, I think that really depends on how the service directive is developed. And so looking at how do we avoid duplication while ensuring that folks have the dental case management aspects accessible to them. So either that means training people up on, I mean, a lot of the, so I want to shout out Leslie Brendan, who was a dental case manager and who participated in the subcommittee. She works at the Department of Health, and she's not a dentist she doesn't have a dental background. And so I don't think that that's necessarily necessary, but I think it would be about striking the right balance between the kind of dental knowledge and what you need to know in order to prepare a patient to undergo complex procedures and ensuring that they have access to whatever referrals and case management that they also need. So I can't give you a specific answer. I think a lot of this comes down to how we've developed. Okay.
Yeah, I was just going to say that one way you could probably try to differentiate it is the way HRSA differentiates between regular case management and medical case management. Because there's specific criteria. It's also captured in the funding separately too, when you report the funding to HRSA.
So the next step for these recommendations is that pending approval by the full council is that it would be asked of the Integration of Care Committee to develop a service directive. And so anyone who's interested in this issue, I would invite you to come to the IOC.
So is the committee issuing a motion for us to vote on? I'm sorry, I'm looking at the time, and I know Adrian has a very robust presentation he wants to do, and I do not want to shortchange him. Okay, ladies, then we're going to wrap it up.
I just wanted to make a point that there's already $2.5 million that that was last year's number. There are 6 agencies that work on the health and hospitals. So I think a better way to maybe think about this is improve coordination and support with the already existing funding when it comes to your first recommendation of care, because I don't see how we could ever match or expend. This is an extremely expensive thing. So I think there might be opportunities to maximize the resources around that and have some coordinated support that can be done with the other recommendations. But I just have concern about recommendation number 1, going straight out care, funding for care, because I think there's a lot of money that's already there that's just not organized in a certain way, and I'm not sure. I wasn't at the meeting, so I'm sure you guys really talked to a lot of people. I didn't see the public health system reflected in.
You're talking
in
about
here.
Part F?
Yeah, I'm talking about Part F, and I didn't see the public health system reported in here. We have 6 facilities that have very robust dental programs that often go above and beyond Part F. So I don't know if that process has been included.
Paul? Yeah. Now I want to be mindful of our time. We really need to move on with this subject, unfortunately. But go ahead, Paul.
We did talk with some of the providers, both here as well as how to also collaborate. This is going to be a cooperation, and it was briefly touched on how Dr. Resnick did state that one of the important things is important. However, there are some procedures that probably can be done, like through an ENT, like a bone graft, who does head and neck, and that's an expense that Medicaid would probably cover if it was done through an ENT versus an oral surgeon. And then the other would be like some of the cleanings, or maybe to talk to some of the dental schools and some of the other already existing programs. So we're really going to have to work, and IOC is going to have a lot of work put out to go ahead and take a look at this. But to sit here now as we can't, is I would then ask Amanda to take over, and then we move this motion and get it over to IOC, and then that's where we can really start to take a look at this.
So I hear your point, and we did discuss this in length. And the $2.5 million in Part F funding, half of those dollars go to academic research. And so cut that in half, and then you put that into a dental chair. The waiting list for those programs is up to 3 or 4 months. And oftentimes what's being provided in those Part F programs are just the basic minimal things. And the things that we talked about, bone grafting and extensive cleanings, are not provided in those programs. So for the poor consumer who doesn't know all this, either they just don't get that service, or they have to like shop around and figure it out on their own. And there's very little guidance for people who are in those situations, who have the tenacity and the will to push forward and get the information they need so that they can get a bone graft, and then they can get an implant and, be well. And a lot of people just don't have that energy.
And I completely agree. I'm only saying our money may be better spent if we prioritize the recommendations around coordination and care management and other supports, because you could just throw lots of money into a bowl of care, and you could find other ways to spend that money that's not all care-based.
So,
that's the only
exactly. So this is the first step. So the second step is trying to develop a service directive that completely spells out what it is that we're going to be paying for. And then that goes to the priority setting committee, where they take into account all the very question that you've asked in putting together a package. And I think because of the enormous size of this and the enormous need of this and how much it could cost, millions of dollars, that the best approach would be, once we go through those 3 steps, is to develop a couple pilot projects and see how well they're received and see where the demand is, so we have a better sense of what the overall funding may be 2, 3, 4 years out.
So, is the committee, it says vote required, so I'm looking for advice from the committee chairs.
Yeah, I was thinking, we were thinking that we needed a vote to be able to move it forward and for the IOC to take it on.
Okay, so do you want to introduce the motion on behalf of the committee?
Put the motion forward.
Put the motion forward, Amanda.
I would like to put the motion forward that the Planning Council accept the draft recommendations of the subcommittee on oral health.
To go to
the IOC for further development.
Okay, that's a motion from the committee. It doesn't need a second. Motion on the floor. Is there any questions on the motion before we vote? All those in favor of the motion? Is there anybody opposed? Okay, it's by unanimous consent. Thank you, yes. I know there's a lot of work that went into that, so I want to thank that committee. Thank Paul for really trying to champion this issue, to identify and outline needs.
All right, just remember to brush and floss. We're going to talk more about this in the fall.
So, even though it's a short shift, but I think this time we actually are giving him a robust time to go through his policy presentation.
I just made that joke. I told Terrence, now I have no excuse. If I'm talking fast, it's because I'm bad at talking like a normal person. So slow me down if need be. But if I do talk fast, it's because I have 5 fewer minutes of time for it. That's my excuse. Okay. Great. So I wanted to cover a couple of current topics in HIV law and policy. I divided it, as usual, between local updates, state updates, and federal updates. And I think, for once, I end on a positive note, so everything is not doom and gloom. Great. So, in terms of local policy activity, I wanted to mention a recent settlement that occurred. You may recall, way back in September of 2016, the Legal Aid Society filed a civil rights class action against the city, as well as a couple of NYPD officers on behalf of women of color, many of whom are transgender, who have been wrongly arrested under the loitering for the purpose of prostitution criminal offense. They brought suit on the ground that the statute is unconstitutional and it's unlawfully enforced by officers who allegedly target women for arrest based on race, ethnicity, gender, gender identity, and or appearance. So I wanted to mention the data is all over the place, but a lot of reports estimate that around 90% of New Yorkers arrested under this loitering for the purpose of prostitution statute are trans women of color. So if that doesn't give you pause, then you know, we have to look more closely. So importantly, in June, a couple weeks ago, the parties announced that they had come to a settlement. So under the settlement, the NYPD agreed to amend its patrol guide to prohibit NYPD officers from relying only on gender, gender identity, clothing, and location to enforce the loitering statute. So officers must now provide more detailed narratives justifying why they detained someone, and also the NYPD Legal Bureau will monitor arrests under the statute. So I haven't had a chance to look at the sort of court documents setting forth the settlement, but I included a link to the original press release announcing the suit a couple years ago, and also I think it's New York Daily News article covering the settlement, in case you're interested. Next, last month, activists and several New York City Council members launched a new initiative called LGBTQ in 2021. It's a grassroots initiative to mentor and promote LGBTQ candidates during the next city council term. So I actually hadn't thought about this before, but right now all 5 openly LGBTQ members of the city council are due to leave office by 2021 due to term limits. So anticipating a sort of dearth of LGBTQ candidates and as well as council members, advocates have come together to educate, build awareness, mentor, and network to make sure that they support LGBTQ candidates for city council across New York City. And I wanted to include this because city council, a number of city council members have been incredibly supportive of our Ending the Epidemic efforts. The New York City Ending the Epidemic planning, including the mayor's $23 million investment to bring new infections down to non-epidemic levels and improve the health and well-being of people with HIV. That was in large part pushed by New York City Council, namely Speaker Corey Johnson. And a number of other openly LGBTQ council members have been very supportive of our work. So it's important that we continue strong relationships with these members and build candidates, as well as important for all New Yorkers. State policy activity. You may have heard that the 2019 state legislative session ended last week, and this was a sort of unprecedented session. If you recall, a couple of meetings ago, I mentioned that for the first time in something like 9 years, the New York State Senate finally had a Democratic majority. And because of that, the legislature was able to push forward a significant number of bills that hadn't seen a lot of movement in previous sessions. So I wanted to sort of very quickly run down which ones are most relevant to our work. So way back in January, the state passed legislation that would enact the Reproductive Health Act and revise existing provisions of the law related to abortion. So this basically codifies Roe v. Wade into New York state law, should anything happen at the federal level to that particular case law. Also in January, the state passed legislation that would prohibit discrimination on the basis of gender identity or expression, and would also include offenses regarding gender identity or expression in the list of those offenses that are subject to treatment as hate crimes. This is GENDA. GENDA has been repeatedly introduced, and it's been repeatedly killed in the Senate. Now that they were able to move it forward in New York State, as of January, it is unlawful to discriminate against someone on the basis of the gender identity or expression. It's super exciting. In New York City, we've had that for a while, but for the rest of the state, this is a major breakthrough. Similarly, also in January, the state legislature enacted legislation that would prohibit mental health professionals from engaging in sexual orientation change efforts with minor patients. This is prohibiting gay conversion therapy for young people. Now, this next set of bills had not been signed into law by the governor, which is why I want to separate them out. But both the Senate and Assembly passed legislation that would prohibit the use of the gay panic defense for certain homicide offenses where a defendant's actions resulted substantially from the discovery, knowledge, or disclosure of the victim's sexual orientation, sex, gender, gender identity, gender expression, or sex assigned at birth. So prior to this, it was lawful to use as a defense to a charge of homicide the fact that they discovered, just found out, or disclosed a victim's sexual orientation, gender, gender identity. It was a valid defense to use. So while I put a little asterisk there, because while the governor has not yet signed it, he did tweet that he intends to, and sort of celebrated the passage of it by the Assembly and Senate as sort of enacting this law. And then two more laws that passed both the Assembly and Senate, but were returned to the Assembly just for sort of housekeeping, cleaning up some of the language, version control. They should probably move forward next session, but I wanted to put this on your radar. Both houses passed legislation that would require the state to provide inmates before they are discharged from correctional facilities information about HIV prevention, how to get an HIV test, and referrals to community-based services related to HIV. And also, not quite signed yet, but probably will be soon, if not in the next session, it is, this legislation would require a hospital who is treating a victim for sexual assault who has been exposed to HIV. The hospital is required to provide a full regimen of PEP medication rather than just 7-day starter pack, which is what we require right now. So I'll keep you posted on when those are signed. So on to federal policy activity. At the last meeting, my colleague Anna mentioned this, and I wanted to just provide an update. If you recall, back in May, the U.S. Department of Health and Human Services published a final notice of a final rule entitled Protecting Statutory Conscious Rights in Healthcare. Essentially, this rule would significantly expand the ability of healthcare providers to withhold treatment, to withhold counseling, to withhold providing medical information based on their religious or moral beliefs, without regard for the needs of the patients. The same day that the notice came out, the city of New York announced it had joined a coalition of 23 other cities and states in a lawsuit seeking declaratory and injunctive relief with regard to the rule. Jan wanted me to also mention that last week, 2 weeks ago, another high-profile suit was filed against HHS regarding this rule. The National Family Planning and Repro Health Association, along with Public Health Solutions, and the ACLU and the NYCHealth announced that they too had filed a suit challenging this new rule. The complaint Similarly to our lawsuit, it seeks declarative and injunctive relief, which is a fancy way of saying, stop, don't do that. And the suit claims that the rules actually radically expand the underlying statutes upon which it relies, contrary to what the intent of the statutes are. And it conflicts with other statutes, including the First and Fifth Amendments. So the National Family Planning Reproductive Health Association issued a memo which does a really excellent job of breaking down what the, something like 60-something pages, what the rule is and the implications it'll have on Title X funded entities. So I included the link at the bottom there. Please take a look, and if you're interested in getting more information on this. The rule actually is not meant to take effect until July, but it's unclear whether our lawsuit as well as this lawsuit will delay that further. News just keeps getting better and better. HHS has been busy. They published a notice of another final rule, this one prohibiting any entity from receiving Title X funding from providing or referring for abortions, even if those services or referrals are paid for by another source. This is known as the gag rule. I think it has been sort of boiling for the last couple of months. Several states sued, securing a nationwide injunction. But the reason I bring this up now is because a couple days ago, the Ninth Circuit Court of Appeals lifted the injunction, which allows the rule to take effect in every state but Maryland, because there's separate litigation happening there. So I wanted to mention this because this is largely seen as an attempt to undermine and in fact defund and close down Planned Parenthood. And I mention that because, as you know, Planned Parenthood provides a number of critical health services to people affected by HIV as well as LGBTQ people. So this is why I thought it important to include this. So definitely keep your eye on this. Not to miss out all the fun that HHS is happening, but yet another federal agency, the U.S. Department of Housing and Urban Development, got in on the rulemaking game. Last month they announced a proposed rule called Revised Requirements under Community Planning and Development Housing Programs. This rule would permit federally funded shelters, homeless shelters, to consider a range of factors in making a determination as to whether someone's sex would affect the admission to that facility. So in other words, any HUD coordinated shelter can now consider privacy, safety, practical concerns, religious beliefs, the individual's sex as reflected in official government documents, as well as the person's gender identity, when they're deciding whether to admit someone into a single-sex facility or a facility that has designated single-sex spaces, like a bathroom, a locker room. They can now make that determination, and advocates fear that this is an attempt to give license to homeless shelters to discriminate against transgender people seeking shelters and other emergency housing. So it's just a proposed rule, but we'll see where this falls out. Next, this is a request from Jan that I actually hadn't heard of, so I'm really glad he brought this up. Over the last couple of months, through two separate actions, Express Scripts excluded 7 HIV drugs for people who are starting HIV treatment. They issued a 2019 National Preferred Formulary Exclusions List, and HIV drug class medications that will be excluded from coverage beginning July 1st include those 7, which I won't mangle the names, but there are 7 drugs that will no longer be covered under this Express Scripts guidance. Following this announcement, the AIDS Institute, not the state health department, but the policy advocacy organization based in DC, they issued a letter to Cigna claiming that the excluded medications are in, quote, the HHS guidelines recommended as the initial regimen in certain conditions. And while several of the preferred alternatives are no longer recommended for the treatment of HIV. In fact, one of the preferred alternatives was even removed from the market in 2018. So obviously this has direct implications on accessing a number of HIV drugs for people who are covered by Express Scripts. And I included some links to a story on this as well as the AIDS Institute letter. Finally, good news. Senator Kamala Harris from California, a couple of weeks ago, introduced the PrEP Access and Coverage Act. As far as I know, this is the first piece of federal legislation that addresses PrEP access and coverage. So this legislation would require all public insurance, all private insurance, to cover the drug, as well as the required tests and the follow-up visits, without a copay, just as the Affordable Care Act requires insurance to cover contraception and other preventive services. The legislation would also fund a grant program to assist jurisdictions in facilitating access to PrEP for people who don't have insurance, or people who may face challenges in accessing the medication. This legislation would authorize funding to cover the cost of the drug, as well as associated tests and follow-up visits. And the grants will also support reaching out to physicians and other providers to increase their understanding of PrEP and the recommended clinical practices for providing care. But there's more. The legislation would also prohibit companies who are selling life insurance, who are selling disability insurance, or who are selling long-term care insurance from denying coverage to customers who take PrEP, and it would also prohibit them from charging these customers higher premiums just because they're taking PrEP. And lastly, the legislation would fund a public education campaign to reduce disparities in access to PrEP and the use of PrEP by educating the public, particularly high-need communities in which PrEP is underutilized. The campaign would educate people about the safety and efficacy of the drug and combat stigma associated with using PrEP. So there's no way we can predict how much traction this legislation will get. Advocates overwhelmingly have had positive reactions to this. I think there is still an underlying sentiment that, well, this is great, by forcing the insurance companies to cover PrEP, these very expensive medications, will no doubt force the insurance companies to raise premiums and find a way to pay for this. So instead of going the route of negotiating with drug companies to lower the cost of PrEP, which is something, what is it, $1,900 a month for one person at current market rates. Instead of going that route, we're just finding money to continue paying the drug company. So that being said, we'll certainly continue to track this and figure out what the reaction will be in Congress.
I have a question on this particular issue, and it's separate from the legislation, but I know I've seen some emails on the national listserv around efforts to make PrEP be classified as level A prevention.
Oh, it happened.
It happens. So doesn't that negate the need for this legislation? Because then insurance companies have to cover it, right, without a copay, if I'm correct?
That provision of the legislation, yes. But, I imagine this would take having sort of a law saying this has to happen as opposed to
a regulatory, right?
Exactly.
Yeah.
I should have mentioned that also. I'm not sure, did it happen since our last meeting? But
it happened recently.
States Preventive Task Force, which is a non-governmental organization that sets forth recommendations around prevention services. They assign grades to certain medications, certain services, to determine whether it can be covered. So PrEP recently, maybe a month ago, received a grade A, which means that it should be covered under the Affordable Care Act provision that requires prevention services to be covered. So it's for example, HIV testing has a grade A. What else?
Yeah, there's a whole bunch of reproductive things that are graded. I don't know the whole list, but mammograms, I think, and things like that are also considered graded.
Because that would only apply then to insurances that must cover prevention services. In other words, Affordable Care Act insurance on the exchange.
And I think it's all become part of the essential basic package that all insurance companies have to cover, but I don't know the details of that.
Well, and also importantly, this it proposes to have copays covered as well. So you can have the best private insurance out there, there still might be copays that might prove cost prohibitive to many people. So this takes a step further, but we'll see where it goes.
So do you have a hand up, Billy?
Yeah, I just wanted to know how Trump administration just awarded like $1 million to end AIDS, to assist certain counties or whatever it is. So how is it going to really affect $1 million going to about 20 different counties or more?
So that's today's announcement?
Yeah.
So just to back up, a couple of months ago, the Trump administration and HHS announced a new initiative to end the epidemic, a plan for America. It identified a handful, more than a handful, 48 counties across the United States that had increased burden of HIV. And just last week, they released the notice of the funding opportunity. So New York City has 4 boroughs that were identified as eligible for this funding. So that's several, almost $300 million, I can't remember offhand.
What I saw,
that was separate. Now today, which I literally just read while I was listening to the oral health presentation, so I can't speak too much to it, but I understand that there was another funding announcement today that was specific to Ryan White.
Yeah.
Let's see. $1 million in Ryan White HIV/AIDS program grants to counties to strengthen efforts to end the HIV epidemic in the U.S. So these were grants to 10 metropolitan areas that are Part 8 jurisdictions to provide technical assistance to enhance efforts to end.
$100,000 a jurisdiction if you evenly spread it. It's like a joke.
Yes, it is. It's $100,000.
Yeah.
And it's for New York.
New York is not on the list.
So I just want to be cognizant of time. Yeah.
What's that?
All right. I know Maria has had her hand up politely. You haven't spoken all day, Maria, so I want to let you get your question in.
How did you come to these 7 medications?
Not me.
Being, how did they come to that?
That's a good question. Does anyone know? I don't know. Cost. I don't
No.
But
I just want to say regarding, I'm sorry, did I overstep my?
You did slightly, my dear, but since you're already at the microphone, go for it. Then we'll let Ronnie and Freddie go.
So I just want to say that some of the providers in the clinic have been following the HHS guidelines, and some of those medications they found that they weren't as effective as the new ones, so they were not going to allow those, because they found that they weren't as effective and they had some severe side effects, and these new ones were much better. So this is why they were discontinuing those.
Ronnie, and then Freddie.
Yes, with regard to those medications, there's litigation going against those medications because they are now toxic to the point that they're causing death. And there is a big class action being formed for people that have the virus, that have been taking those medications for a long period of time. According to the suit, they're alleging that the manufacturers knew that there were safer drugs out, like the new ones like the Genvoya, instead of Distribul, and that they withheld those newer, more safer medications, and now it resulted in liver problems and bone loss. So that's why they probably took it off of Express Scripts, because they didn't want to be associated with those medications.
If anyone comes across more information, if you have it handy, will you send it my way just for my own awareness?
That's your phone number.
Let Freddie go, and then we have time. Go ahead.
Thank you for the update. I just want to point out to everyone that the guard rule is not just affecting the family planning facilities. The guard rule also will affect anyone receiving federal funds because it's about health services, and although it's supposed to be in effect being effective in July, and right now, even in your state, as liberal as we are planning to lose a lot of money. That will be really, hospital, everyone will have that. So it's not just family planning or Planned Parenthood, but it's anyone receiving federal funds. So we have to be on the lookout for that. Thanks.
Thank you. Mr. Carr, now we need to wrap this up.
It has to do with Truvada, and that for 15 years, Gilead sat on information knowing that it directly causes renal failure and osteoarthritis and bone loss. It's the same thing. There are already lawsuits all around. If you go on like Facebook,
I saw some ads like on Facebook.
Yeah, they're reaching out to people who have taken the drug and who have had any type of kidney problem or any type of bone loss or osteoarthritis.
Thank you.
It also talks about bone loss as well with people who have problems with oral health as well. So we know that.
Okay, we got 4 minutes before this council meeting is supposed to end. Are there any last comments before I go to public comment? Okay,
Can
go
I
ahead.
I just make one more plug for tonight's event. I do want to mention for our Made Equal campaign that Amber mentioned earlier and that we had a conversation about. Made Equal is not solely an HIV prevention campaign. So you recall we've had a couple of campaigns that promoted PrEP. Remember, Living Shore promoted PrEP for women, Listos presented PrEP for Latinos. This campaign simply promotes the idea of you equals you. So the name of it reflects the fact that we've taken the you equals you message and tailored it to New York City. So part of the campaign wants to promote the idea that anyone has access to HIV treatment regardless of immigration status and regardless of income level. This is stuff that not many jurisdictions can say. So that's why it's called Made Equal as opposed to you equals you. And you remember Freddie from Prevention came to the Planning Council meeting and talked a bit about some of our campaigns. I'm sure they'd be happy to come to the next meeting and talk about the You Equals You Made Equal campaign, but just to be clear, it's not a prevention campaign, it's not a care and treatment campaign, it's sort of a campaign that addresses all of these matters as best we can. And just another plug for the party tonight, it's going to be super fun. The information is in the grantees report. Dimitri will be there, Oni will be there, we have a couple of community members and people who star in the campaign come and talk a little bit about how You Equals You has changed their experience, and everybody should come out. It's at 5:30 to 8 this evening. Thank you.
Great. Thank you, Adrian. Thank you very much for all that. So, we have just a few minutes left. Is there any public comment, new business, thoughts of the day before I wrap this up? Because it's hot. It's hot in here. Happy Pride, everybody. For those.
Freddie first.
Freddie.
Just an announcement that CHM will be hosting its 9th annual conference on transgender health on October 24th and 25th, and it will be held again at the new school. Hope everyone.
All right, thank you, everybody. One more month to go.
Of course.